now. Thank you.
Okay, thank you, Miranda. So yes, as Miranda said, my name is Tami Grunewald. I'm a consultant medical oncologist currently working at Barts Health NHS Trust, and I treat gynae cancers and melanoma. And I'm going to talk to you tonight about systemic anti-cancer therapies. So just as an introduction, so there are different modes of anti-cancer treatment. I'm going to talk about these four here, which are systemic therapies, but not forgetting that another major role that surgery and radiotherapy also make up part of our treatment paradigm for our patients. So just as an overview, what am I going to talk about? I'm going to go through the different systemic anti-cancer treatments, and that's going to be chemotherapy, targeted therapies, endocrine or hormonal therapies, and immunotherapy. I'm going to talk about the toxicities and how they differ, and also I'm going to take you through some case studies of patients that I have seen, and also how these may relate to you in your jobs, which are not necessarily going to be oncology jobs, but as surgical or medical SHOs or junior doctors. So first of all, I'm just going to do a brief introduction on how do we stage cancer, because often staging of the cancer will help, will give us a guide on how to manage these patients. So we use, in the majority of solid tumours, we use a staging system called the TNM staging, which looks at the tumour, essentially how big the tumour is, does it penetrate through the wall of whatever organ it's affecting. Has it then spread to the lymph nodes? Because nodal metastatic disease seems to be the first place where cancer spreads in the majority of patients. And then does it have, is there any evidence of distant metastatic disease? And based on the TNM staging, we then are able to stage the cancer from stage 1, which is early stage disease, to stage 4, which is disease with which has metastasized outside of the primary site of the cancer. So what are the goals of treatment? So we talk about goals of treatment in 3 ways. So the first one is curative treatment, and that can be given in one of 2 ways. The first way is adjuvant therapy, which is generally given after a patient has had an operation for the cancer and there's no visible signs of cancer. And the goal of that treatment is to try and reduce the risk of the cancer coming back. And that's because sometimes, occasionally, there are cancer cells that have already metastasized that are not visible on scans or left behind after treatment, and this is kind of an insurance policy to try and prevent the cancer from relapse. The other way that we give curative intent treatment is in the neoadjuvant setting, which means a patient has presented with a large primary tumour that is either not resectable or would require a very large operation, and we give some treatment in order to reduce the size or reduce the disease burden, and then to allow the surgeons to operate and get the cancer out fully. Following on from that, and generally after we've given either adjuvant or neoadjuvant treatments and patients have had have had a good response, in some cancers we then go on to give some maintenance treatment, and this tends to be lower doses of oral agents in most settings, but occasionally intravenous. And the aim of these are either to prevent relapse again or to maintain disease control if we've managed to reduce the burden of disease. And then finally, we can give palliative chemotherapy or palliative systemic therapy. And the goal of that is not necessarily to cure the cancer, but to prolong life, and especially if patients are very symptomatic from their disease, or maintain the quality of life. And sometimes patients can be on palliative treatment for months or even years. So how do we, as oncologists, assess fitness for treatment? And what we need is really an objective way to do that. And the way that we do that is ECOG performance status. And we have a grading of 0 to 5, although 5 is dead. So we tend to use 0 to 4. And if you've looked after oncology patients, we'll often document what a patient's performance status is. Generally, we would offer systemic therapy to patients with an ECOG of 0 to 2. In clinical trials, if you've ever read any clinical trials, the majority of patients that are allowed into clinical trials have got a performance status of 0 to 1. So the patients do need to be fairly fit in order to tolerate and to benefit from systemic treatment. So I'm first going to talk a little bit about chemotherapy. Chemotherapy is used in most solid tumours. Some cancers are more chemosensitive than others, and we can give them either as single agents, or often we give them as doublets or even triplet combinations of treatments. And they can be given either orally, intravenously or subcutaneously, depending on the formulation of the drug. So if you can think back to medical school, mine was a very long time ago, think about our biology of the cell cycle. And essentially the way that chemotherapy works is most drugs will target some point in the cell cycle. And essentially what chemotherapy does is it tries to kill rapidly dividing cells, which are what cancer cells are. So if you can have a look, this is just a more in-depth diagram of how cells divide, and various different chemotherapy agents will act on different parts of the cell cycle and try and prevent and cause cancer cell death or cell growth. So for example, taxanes will inhibit microtubule function, and then there's antifolate drugs, and lots of different drugs will work in different ways, but essentially they have a similar mechanism of action. And because chemotherapy targets rapidly dividing cells, it's not only cancer cells that they kill, but they can affect other cells. And so there are quite a lot of potential toxicities from chemotherapy, as we can see in this diagram here. Some of them are acute toxicities, so toxicities that we see immediately or within a few days of starting chemotherapy. And there are some that are later toxicities that we do have to warn patients of, such as nerve damage, so neuropathy, which can be long-term cardiac damage, and potentially they can also cause second malignancies. And it's really important to have a good idea of what these potential side effects are in order to obtain informed consent when you're consenting someone to go ahead with chemotherapy. The other thing that we have to think about also is that there are some toxicities that can be life-threatening, and I'll talk a little bit about one of those a bit later. And these are things that you need to be aware of, because if you're in the emergency department admitting someone with a potential chemotherapy side effect, it's important just to have a bit of an idea of what sort of side effects we might see. So how do we grade toxicity? Again, it's very useful to have an objective way of grading our toxicities, and we use the National Cancer Institute's common terminology criteria for adverse events. And that way, if different medical professionals are seeing the patients on different days, you can actually establish how severe the toxicity was and is it getting better. And how do we manage these toxicities? So most trusts will have either an acute oncology service, and most trusts will also have some guidelines of how to manage the most common toxicities that we see from chemotherapy. And these are an example of some of the guidelines that we use in Barts Health. And we have a fantastic acute oncology service, which is a nurse-led service Monday to Friday, which is also supported by a consultant oncologist 3 times a week. There's also 24-hour oncology support available, so either a chemotherapy hotline, which is manned by one of our chemotherapy nurses, where patients can call and get advice 24 hours a day, as well as a registrar and a consultant on call if you need advice out of hours. And very importantly, when we see patients in clinic and we consent them for chemotherapy, we have to get written informed consent before starting any treatment. We talk to them in clinic about the potential side effects. We give them normally Macmillan information sheets about the regimen that we're recommending, and then we get them to sign a consent form. There are standards, just chemotherapy trust consent forms, but more and more we're moving towards these CRUK consent forms, which are standardized consent forms. And actually, this is an example of one for just any sort of systemic anti-cancer treatment. But if you go onto the CRUK website, you'll actually find that most of the regimens have their own consent form that we're trying to use in our clinics now. So I'm just going to finish this chemotherapy section with a case study of a patient that I recently saw in one of my acute oncology ward rounds. She was a 74-year-old female with past medical history of hypertension, high cholesterol, some tinnitus, and an unprovoked DVT a few years ago. She was on some antihypertensives, some anti-cholesterol medication, and also an antidepressant, and had no known drug allergies. Family history, had bladder cancer. Her mother had bladder cancer at the age of 83, and she had a performance status of 1. And so she presented in February of this year with a self-detected left breast mass. She had some imaging which confirmed a single breast mass with also a pathological looking axillary node, and a biopsy confirmed a grade 2 invasive ductal carcinoma of her breast, which was hormone receptor positive. So that's what the ER and the PR means, so estrogen and progesterone receptor positive, and also was HER2 positive. So that's another biomarker that we look at in breast cancer, and we'll talk a bit about biomarkers later. She had staging scans to try in order to determine what stage she was, and these were thankfully negative with no evidence of metastatic disease. And this was a patient who was planned for neoadjuvant chemotherapy because she had a large breast mass. She had some auxiliary lymph node that looked like it was involved, and so she started her neoadjuvant chemotherapy on the 3rd of April. On the 14th of April, she called our chemotherapy hotline and told the nurses that she was febrile with a temperature of 38 degrees. She was feeling unwell. She had a sore mouth, and she was also vomiting. And she was sent to her local A&E, and where she was seen, and a full septic screen was sent off, and she was given intravenous antibiotics for a presumed neutropenic fever, but no clear source of infection. And when her bloods did come back, her white cell count was 0.02 with neutrophils of 0. And she was commenced on GCSF to try and boost her white cell count, and was on broad spectrum antibiotics. So febrile neutropenia is something that we all need to be aware of, and you will encounter this wherever you work, and it's an important toxicity that we need to recognise and treat fairly quickly. And the reason for that is if we don't treat it quickly, then it can be potentially life-threatening. It's one of the most common and most serious, and can be a very serious complication of chemotherapy. And really the thing, if you're going to remember one thing from tonight's talk, that if you suspect a patient has a neutropenic fever, then you need to initiate antibiotics really for within an hour of them hitting the emergency department. And so what we say, and what the trust guidelines will say, is that even you don't need to wait for blood tests to come back. You send off a septic screen and you give them some antibiotics, and every trust will have guidelines of what antibiotics to give these patients. And we also give patients a little card to say they're having chemotherapy and they're at risk of neutropenic fever. So that's chemo. I might just continue, and then we can have questions at the end, I think, just in the interest of time, if that's okay. But if you do have any burning questions, I'm happy to be interrupted. So the next treatment that I'm going to talk about is targeted therapy. So Hanahan and Weinberg in 2011 gave this lovely picture of the hallmarks of cancer. So what drives cancers to grow? And there's lots of things that drive cancers to grow, which means there's lots of things that we can potentially target to stop them growing. More recently, we've got many more treatments that have come out that are not necessarily chemotherapy agents, but they're more targeted therapies. And that's because we've got more personalized medicine, where we've got patients who come in with signs and symptoms of cancer or with a cancer, and then we have a look at the cancer, and we want to try and understand what makes these cancers grow. So in some of these patients, something X will be causing it to grow, and others something Y will be causing it to grow. And can we target that in order to prevent their cancer from growing? But it wouldn't necessarily work in somebody else who's got a different sort of cancer. So there's looking at this hallmarks of cancer. There are a lot of proteins, genes that can be targeted, as you can see here, in order to prevent the cancer from growing. And we do have some drugs to target this, for example, EGFR, PI3 kinase inhibitors, mTOR inhibitors, BRAF inhibitors, that we use in some solid tumours. So how do targeted therapies work? So if you can see here, without a molecular, we've got all of these different proteins that cause cell proliferation, cell growth, cell survival, and ultimately metastases. And if we block any of these at certain points in their pathway, that will stop that cell growth and proliferation. So essentially, targeted therapies will act on these specific molecular targets, and they're designed to interact with these targets and to stop cancer cell growth rather than actually killing the cells themselves. So we've got a number of different sorts of targeted therapies. We can kind of split them into small molecule compounds or monoclonal antibodies. Small molecule compounds are typically developed for targets inside the cell, and they're small, so they can enter the cells quite easily, whereas monoclonal antibodies are generally quite large and can't enter the cells, so they're used for targets that are outside the cells or on the cell surface. What are the differences between the two? So the small molecule inhibitors, which often end with a nib, are generally oral agents, and as I've mentioned before, their targets can be within the cell, and they're expensive, but not that expensive. They can diffuse quite easily, and can also potentially inhibit multiple different targets. But the more targets that you're inhibiting, the higher the side effect, the more side effects you may get with these drugs. They tend to bind and inhibit kinases. Monoclonal antibodies, which tend to end with a MAB, are generally intravenous. They target cell surface proteins only and are very expensive. They don't diffuse far from the blood vessels. They tend to block a single target or block receptors. So this is just an example, a slide that highlights the number of different drugs that we have, and this certainly is not all of the medications that we have. But over the years, as you can see, kind of 2001 there were one, but in the last decade or last 15 years or so, we've had a number of different new targeted agents that have come about, and these are some examples of some monoclonal antibodies that are used in solid tumours as well. I think at your stage in training, we wouldn't expect you to know what drugs that we use, but I think it's important for you to know the effects of the drugs and the different classes of drugs that we use. So what toxicities do we see with the different targeted therapies? And the answer is that they can involve multiple organs. We say that these drugs are generally better tolerated than chemotherapy, but that's not always the case. But what we do see with these drugs, particularly with the oral targeted therapies, that if someone does get a side effect and we either stop the treatment or just delay it for a while and give them a break, those side effects do tend to go away. And then sometimes we can either start at the same dose or a lower dose to try and reduce the risk of those side effects coming back. And they can cause kind of target-specific toxicities as well, depending on what we're targeting. So I'm just going to give you a bit of an example about how melanoma has changed over the years, because I treat melanomas, and also that this is a cancer that we can give either immunotherapy to or targeted therapy to in the 50% of patients that have a mutation that is targetable. And again, as you can see, back in the 90s and early 2000s, we didn't have very effective treatment for melanoma, and now in the 2020 era plus, we've got lots of different treatments, and actually chemotherapy doesn't really play a role in this cancer anymore. So I'm just going to give you an example of a case study of one of our patients who I met in clinic last year. He was a 67-year-old gentleman with a significant past medical history of alcoholic cirrhosis, and actually had an admission to hospital earlier in the year with decompensated liver disease. He has a history of ischemic heart disease with a myocardial infarction in 2015, also had some COPD and hypertension, and was on a number of different medications. However, although he had a significant past medical history, his performance status was 0. So in July of last year, he presented with a pigmented lesion on his right chest, which was excised, and it was noted to be a very large and very thick superficial spreading melanoma. He went on to have a wide local excision and sentinel node biopsy to show, and he had one lymph node involved. So he had his final stage was stage 3C melanoma, so high-risk melanoma for relapse. And also when we looked under the microscope and we sent it for molecular testing, he was noticed to have a BRAF mutation, which is seen in about 50% of patients with melanoma. He was then referred to our clinic for a discussion and consideration of adjuvant treatment to try and reduce the risk of the cancer coming back in the future. So he actually had an option of either having targeted therapy because he had a BRAF mutation, or immunotherapy, which we can give to all patients with high-risk melanoma in the adjuvant setting. In discussion with his hepatologist, we decided that actually targeted therapy was probably the way to go because there was a risk of long-term toxicities, particularly liver damage with immune checkpoint inhibitors, whereas with targeted therapies, when we stop the drug, the side effects tend to disappear and they don't tend to be long-term. So following cycle 1 of treatment, he presented with a skin rash, which is very commonly seen with the tyrosine kinase inhibitors or targeted therapies that we use, which improve just with topical treatment, although if they are very bad, sometimes we do need to give steroids. But following cycle 2, we noted that his liver function was starting to go off and he had some deterioration in his synthetic liver function. So his albumin had dropped, his INR was going up, his platelets were dropped, and there was a rise in his ALT. And at that point, from discussion with the patient and with his hepatologist, we decided to stop adjuvant treatment because at this stage, the risks of treatment outweigh the benefits. However, if he does relapse or his cancer does come back and metastasize in the future, we'll have to reassess the situation because obviously the benefits of treatment at that stage might outweigh the risks. So these are just some of the things that we have to think about in the clinic. So it's not just about the treatments that we give, but we do have to look at the patient as a whole. So the next sort of targeted agents that we use, predominantly in bowel cancers, and I use a lot in ovarian cancer, the anti-angiogenics. And so how do they work? Essentially, in order for something to grow, it needs a blood supply. And when tumours have a blood supply that goes to it and it causes angiogenesis, and essentially it allows the tumour to grow, but these blood vessels are generally abnormal, and so VEGF is one of the targets that we target to try and prevent new blood vessels from forming. Again, there's a number of different targets that we can use in order to prevent angiogenesis, and some of these are oral agents, and bevacizumab is the one that I use quite a lot, which is an intravenous agent that's given once every 3 weeks. It's normally started in combination with chemotherapy and then continued on as maintenance treatment, as we discussed before, and I use it a lot in ovarian cancer. So the toxicities from anti-VEGF therapy tend to differ from that of chemotherapy due to its mechanism of action, and the main things that we have to be aware of is that they can cause high blood pressure, they can cause leaking of protein from your urine, there's a risk of bleeding or hemorrhage due to abnormal blood vessels, there is a risk of fistulas or abscess formation, and a small risk of gastrointestinal perforation. And there's also a high risk of thromboembolic events, which patients with cancer already are at high risk of, and they can impair wound healing. So if patients are going for any large surgical procedures, then we need to hold the treatment for at least 4 to 6 weeks before and 4 to 6 weeks after their surgery. Another targeted agent that we tend to use, and predominantly again in ovarian cancer, but has been used in other cancers as well, are PARP inhibitors. And homologous recombination deficiency is what we're trying to target. So it's a biomarker that we're looking at, and as you know, DNA is constantly being damaged and being repaired, and we've got genes that help repair those damaged chromosomes. However, if cells can't correctly repair their damage, they're known as cells which have got some sort of homologous recombination deficiency. And this is caused by a number of different genetic mutations, but the one that you're probably familiar with is the BRCA mutation, which makes patients at increased risk of breast and ovarian cancer. So how do PARP inhibitors work? So PARP is an enzyme which is involved in DNA, in single strands of breaks of DNA. If we so we have a single strand break, which if the PARP enzyme gets involved, it will then try and repair it. If it is unable to be repaired because we've blocked the PARP with a PARP inhibitor, then it will cause a double-stranded DNA break. If we have a patient with normal or BRCA or normal genes that can effectively fix that double-stranded break, then it will fix the cell and you'll have continued cell proliferation. However, if you block PARP and then you have an HRD deficient pathway, then there's no way of those double-stranded breaks from being repaired, and it causes cell death, and that's something called synthetic lethality. There are 3 PARP inhibitors that we use in ovarian cancer: olaparib, niraparib, and rucaparib. And the main toxicities from these drugs are hematological. So we see quite a lot of anemia with one of the drugs. We see quite significant and profound. We can see quite significant and profound thrombocytopenia, neutropenia. And again, as I talked about earlier in talking about long-term toxicities, there's approximately 1% chance of getting AML or myelodysplastic syndrome sometime in the future. They can cause a lot of GI side effects, fatigue, headaches, high blood pressure, deranged NFTs, and so on. So I'm just going to give you an example of a patient who actually has, with ovarian cancer, who is on maintenance treatment with both bevacizumab and olaparib. So she's a 48-year-old female who presented last year with no significant past medical history, but was quite fairly symptomatic. So had a performance status of 1 when we first met her in the clinic. So in January 2021, she presented with a large pleural effusion, and at that stage, cytology of the pleural effusion was negative, and the working diagnosis at that time was a pneumonia with a large parapneumonic effusion. However, in February of 2021, she represented with shortness of breath, and at that stage had a CT chest abdomen pelvis, which showed a very large right-sided pleural effusion with mediastinal shift. At that point, she had ascites and peritoneal disease, which is what we very commonly seen with ovarian cancer. She had a pleural biopsy, which confirmed a stage 4A high-grade serous ovarian cancer, and she commenced neoadjuvant chemotherapy. So she had neoadjuvant treatment because she had a large burden of disease. She had pleural-based disease, and at that point, her disease was not operable. She had 3 cycles of neoadjuvant treatment, went on to have interval debulking surgery, and where they managed to take out all of her tumour, and there was no evidence of any residual disease after her operation. At that point, we sent her tumour off for biomarker testing. And although she didn't have any BRCA mutations, so she didn't have a germline BRCA mutations, there was no inherited mutation that would have caused her ovarian cancer. She was noticed to have HRD. She was HRD positive, which is what we talked about with PARP inhibitors. So she then went on to have a further 3 cycles of chemotherapy, and we added in bevacizumab, one of the anti-angiogenic drugs, with her cycle 6 of chemotherapy. So it was about 8 to 10 weeks following her large surgery. And then we started olaparib, which is a PARP inhibitor, when she completed her chemotherapy and completed her 15 months of bevacizumab, and is now on olaparib alone, and with no evidence of disease. And so this is an example of a patient who's had neoadjuvant chemotherapy, she's had surgery, and she's now on combination maintenance treatments. The first one we give for 15 months, and the second one we give for 2 years. So the next drugs that I'm going to talk about are hormonal or endocrine therapies. How do they work? So this is our pituitary glands, we've got ovaries, adrenal glands that all produce hormones, and the drugs that we can use either block off our FSH or LH, and essentially estrogen or testosterone production, because we essentially use hormone agents in mostly in breast cancers and prostate cancers. So majority of breast cancers are hormone dependent. When we look in the microscope in any patient that's diagnosed with breast cancer, we have a look at their estrogen receptor and if they're positive, and also their progesterone receptors, and they're the primary regulators of breast tissue growth and differentiation. There's a number of different endocrine therapies that we can use, or anti-estrogens that we can use in breast cancer. Some of them are oral, some of them are subcutaneous injections. And again, with prostate cancer, is driven by testosterone, and generally the first line of treatment for prostate cancer is essentially making a man castrate, so blocking off their testosterone production. And again, we can do that either by blocking off the pituitary hormones or by blocking off testosterone from the testes themselves. And these are some examples of some of the anti-androgens or hormonal agents that are used in prostate cancer. What are the symptoms of endocrine therapy? So as you can imagine, if we're blocking off estrogen and progesterone production, then we're pushing patients into menopause or men into andropause. And as you can see, it can cause a lot of different symptoms that have a major impact on one's quality of life. And these are things that we really need to be aware of when we're consenting patients for treatment, and also how to manage these, because these patients can be on hormonal agents for a number of years. So this is a case study of a gentleman with no significant past medical history, presented with a performance status of 1. Sorry, I've left that off the slide. And presented in July 2020 with metastatic prostate cancer. And he was given a combination of chemotherapy and hormonal therapy at the time, and he still remains on hormonal therapy. And the biggest thing that he's suffering from at the moment is hot flushes. And he's tried a lot of different agents, so antidepressants, and so on, and they're really significantly impacting his quality of life. But the other considerations that we need to take into account with patients on long-term hormonal therapy is their bone health. So they're at risk of osteoporosis, so we would always do a baseline DEXA scan. They should be on calcium and vitamin D. Need to consider bisphosphonates if they have evidence of osteoporosis, and also the psychological support, because there can be lots of mood changes and loss of libido, and particularly in men, impotence, when we basically cut off their testosterone production. So lastly, I'm just going to talk a little bit about immunotherapy, which sometimes comes under the umbrella of targeted therapy, but I think is really a treatment in itself, and works very differently to the other therapies that we've talked about so far this evening. They're fairly novel agents. They work by trying to activate the immune system to fight against the cancer, and we're increasingly using them in clinic. We use them both in the adjuvant setting and in the metastatic setting, and there are lots of clinical trials still trying to establish the role of immunotherapy in some cancers that don't seem to respond as well. And as junior doctors, you're very likely to see your patients with immunotherapy toxicities, regardless of the specialty that you work in or the hospital that you're working in. So how do they work is essentially there's two types that we tend to use, and there's a CTLA-4 pathway, which we block with a drug called ipilimumab, which is the one that we use most commonly, and then we've got the PD-1 pathway. So these are all inhibitory proteins that inhibit T-cell activation. And so what we're trying to do is when the PD-1 antibody binds the PD-L1 on the tumour, they will prevent the T cell from killing the cancer. What we're doing by giving an anti-PD-1 antibody is preventing that inhibition and allowing the immune system to therefore fight and kill the cancer cell. Where do we use immunotherapy? Well, we use them in a lot of solid tumours. We use them in melanoma, lung cancer, bladder cancers, triple-negative breast cancer, renal cancers, and so on. Some of the drugs that you may encounter, ipilimumab, which is the anti-CTLA-4 that we use, and nivolumab, pembrolizumab are PD-1 inhibitors, and these are our PD-L1 inhibitors. I think the thing to kind of take into account with these drugs is that these drugs tend to take time to work. So chemotherapy will kill rapidly dividing cells, and therefore we should see a response to treatment fairly quickly. Targeted therapies will target the the protein or the abnormal protein that's driving the cancer to grow, and will again work quite quickly. With immunotherapy, they don't work quickly. So if you have someone that's come in with a very large burden of disease and is very symptomatic, they're unlikely to benefit from immunotherapy in the way that they may benefit from some of the other agents that we can use. However, saying that, if one does respond, the clinical trials and even in our practice, we see durable responses, so long-term responses with these treatments. But what toxicities can we see? So the answer is any. So what we're trying to do is trying to activate the immune system. So what do they sometimes do is that they tell the immune system to target something that should be there and it recognizes it as foreign. So it's basically any autoimmune or immune-mediated side effect. So it can affect any organ in the body. If you give combination treatments, that's a CTLA-4 with a PD-1 inhibitor, the risk of some sort of side effect is close to 100%, with about 60% chance of getting a significant side effect requiring high doses of steroids or hospital admission. And with a single agent, the risk of a high-grade toxicity is probably about half of that, so about 30%. And why do they occur? As I've said before, basically the immune system is attacking itself, and it results in inflammation and dysfunction. The most common toxicities that we see in clinic is probably colitis, so diarrhea. So often see abnormal LFT, so just a rise in their ALT generally, so skin rashes, but it can affect any organ in the body. How might patients present? Well, with anything. And sometimes they just present with just feeling non-specifically unwell. And there's nothing that you can really pinpoint when you see them in clinic or you see them in the emergency department, but they just feel not themselves. Or they might present with, significant diarrhea, chest pain if it's myocarditis, palpitations, rashes, some visual disturbances. So it's just, you have to keep an open mind when someone comes in and says they're just not feeling well and they're on immunotherapy. So as with the other guidelines, we have specific immunotherapy related guidelines because the management of these side effects are different to the management of the side effects that we see with chemotherapy. So what side effects, so how do you manage these? So I think the main thing is important to note is that it's really important to manage these with a good team, and it's important to involve the organ specific specialists early. So the majority of patients we have to treat with immunosuppression. So we give high doses of steroids. So if it's a grade 2 toxicity, then we may be able to just give oral steroids. We normally start at 1 milligram per kilogram. So you've got an average 70-year-old male or female, 70 kilo male or female, then you give them 70 milligrams of prednisolone. So they're not insignificant doses of steroids. If they're really bad, then we do have to give them IV methylprednisolone and admit them to hospital. If they don't respond to high dose of steroids, then we do then need to consider some steroid sparing agents, because obviously we don't want patients on steroids for a long time. And then if we do think they're going to end up being on steroids for quite a while, then we have to think about what are these potential side effects of the steroids. So think about bone health. We would always start a proton pump inhibitor if we're starting someone on high doses of steroids, have to monitor their blood sugars. And if we think they're going to be on high doses of 25 milligrams or more, then we have to think about PCP prophylaxis, as they would be at risk of fungal infections on long-term steroids. We have to monitor these patients really carefully, and we have to wean their steroids quite slowly, because we can see a relapse of their symptoms if we go down too quickly. The only caveat to that is if we see any endocrine dysfunction. So the most commonly we see thyroiditis. So patients will often become hyperthyroid, and then their thyroid will burn out, and then they will be hypothyroid, and then we give them hormone replacement therapy, so thyroxine. And the important thing to note with the endocrine dysfunction is that if they do have issues with any of their hormone glands, and generally they're going to end up on that hormone replacement therapy for the rest of their life. So this is not a reversible toxicity. So this is a case study of a young, unfortunate lady who is currently under my care and presented in 2021 with a 1-year history of chest pain. And this was during COVID and virtual reviews, and she was at that time advised to take analgesia, but her symptoms continued to get worse. And alongside that, she had some unintentional weight loss of about 1.5 stone. There wasn't any associated shortness of breath or cough or hemoptysis or fever. And really her only significant past medical history was melanoma, which was excised 11 years prior to that. And it was a high-risk melanoma, and she stayed under the dermatology team for 5 years of surveillance and was therefore discharged from their care in 2015. She wasn't on any regular medications, didn't have any allergies, lived alone, good performance status, and just had an 8-year history of smoking. So she presented to her emergency department because her symptoms weren't improving, and a chest X-ray showed a lesion in the left lower zone. She had a CT chest abdo-pelvis, which then confirmed several lung lesions, some lymph nodes in her chest, and also a liver metastasis. She went on to have a CT-guided biopsy of one of the lung masses, and this came back with metastatic melanoma, and she was found to have a BRAF mutation. So she again had options of treatment. So one option was immunotherapy, and one option was BRAF targeted therapy. And we know from data that from clinical trials that if we've got a patient with a good performance status, then we should be giving them immunotherapy before we consider targeted therapy. So she was well enough for immunotherapy, so we started her on ipilimumab and nivolumab, which is the combination treatment that we give patients with metastatic melanoma. And after the first cycle, she was admitted to hospital with fevers. And so whilst she's not at risk of neutropenic fever per se, we do sometimes see fevers with immunotherapy, and her blood cultures were negative. She was treated for an infection and treated with broad-spectrum antibiotics, and she also developed a rash and some fatigue secondary to her treatment. She then, on routine blood tests in April, the following year after starting treatment, she initially had a suppressed TSH, which then burnt itself out and then ended up hypothyroid and was commenced on levothyroxine. She needed regular monitoring of her thyroid function tests in order to titrate up to the adequate dose of thyroxine, which can take a number of months to normalise again. She then had a CT scan after 4 cycles of ipi-nivo, and she had some new lung lesions, but a reduction in the size of her lung and liver mets. And so at that time, she was deriving clinical benefit, and the lung lesions, we weren't 100% sure that this was definitely new metastatic disease. So the decision at that time was to continue maintenance nivolumab despite some of the toxicities that she's already had. So then she presented in May last year with feeling generally unwell, nausea, crampy abdominal pain, and bloods revealed a grade 2 rise in her ALT. So she had a transaminitis. She was treated with a PPI with anti-sickness medication, and then commenced on a fairly low dose of prednisolone because it was only a slight rise in her ALT. She then developed diarrhea, so bowels opening 10 to 20 times a day. And this was treated as an immune-mediated colitis, and she required actually intravenous methylprednisolone, but really didn't improve significantly. And every time we tried to wean the steroids or switch them to oral steroids, and the symptoms came back. And she had a flexible sigmoidoscopy, which confirmed a severe colitis. And in the end, she required a fairly long course of steroids and 3 doses of infliximab, which is a steroid-sparing agent that we use with colitis. Once the toxicity settled, we continued on the maintenance nivolumab because it was holding her disease. And then she developed really terrible joint aches and pains, and was, restarted on some steroids with very minimal symptom relief. And she was requiring quite a lot of pain relief, and it was really impacting her quality of life. She was then sent to the rheumatologist for review. She was given some intra-articular steroid injections. She was commenced on methotrexate, a steroid-sparing agent, with really very minimal relief of her symptoms. In October last year, there was a marginal increase in size of the left lower lobe lesions, but no new disease. But at that point, because of all of her toxicities and its impact on her quality of life, we made a decision that as a team to stop her immunotherapy and switch to targeted therapy. And at the moment, she is still really suffering from her joint aches and pains. She's very Cushingoid because she's been on and off steroids for months and months and months. And it's really impacting her quality of life. So this patient, in summary, had a number of different toxicities along the way with her immunotherapy. She's hypothyroid and is likely to remain on thyroxine now for the rest of her life. She had liver toxicity, she had bowel toxicity, and she's got, joint toxicity, which is really significantly impacting her quality of life and may never improve fully, despite what we're doing. So in summary, so that was a very whiz-pop tour through some of the systemic therapies that we give to patients with cancer. We've got different agents that we can use. They work in different ways. They've got different side effect profile, and they all have their limitations. But we do have a number of different options, which is great. The time to response to these agents are very different with different agents, and actually oncology is a very exciting specialty at the moment because there is personalized medicine where there's a lot of research going on in the labs and trying to understand what causes cancers to grow, trying to individualize our management for every patient, which is why biopsies are incredibly important. But whilst we're doing that, our patients are living longer. There is a risk of significant toxicities, and the management of all of these different side effects differ. So it's just good to remember that there is, every hospital has some sort of acute oncology service. They're a fantastic resource, and there's always some trust guidelines and people that you can turn to for help for these patients. And I think that is it for me for this evening. Does anyone have any questions? I can see here that I'm just looking at so there's a question at 7:54 p.m. Do you need to wean the dose of steroids down to a certain level prior to restarting the immunotherapy agent? And the answer to that is yes. So ideally, we want them off steroids before restarting, because what we're trying to do with the immunotherapy is trying to enhance the immune system. But steroids will dampen the immune system. So very occasionally we'll restart immunotherapy when they're down to 10 milligrams of prednisolone, but ideally we want them off steroids before we restart. Sometimes if it does take a long time or they've had really, really significant toxicities, we will stop treatment. But what we've seen in clinical trials, that even if we've had to stop treatment early, we still see ongoing responses, even with maybe what we think is a suboptimal number of cycles of treatment that we can give.
There are two other questions. I don't know if you've seen the ones higher up as well.
I can't. No, I haven't seen the ones higher up. Yeah. Sorry.
We've got what is the antibiotic choice in febrile neutropenia?
So every trust will have different guidelines. So we use tazocin and a stat dose of amikacin at Barts. When I was training, I think it was tazocin and gentamicin, but I think we've moved away from but every trust will have guidelines as to what. So it's just broad spectrum antibiotics. And then, once cultures come back or once their counts start to recover, or if you have a clear source of infection, then you may target the antibiotics towards, if it's definitely chest, then you might give them antibiotics to cover their chest. Yeah, go on, Ramza.
We've got, is transaminitis connected with autoimmune hepatitis after immunotherapy?
As in, do they have long-term toxic? I think what you mean by that question is do they end up with some sort of long-term hepatitis? And the answer is generally what we see is is just a rise in the ALT first of all, which tends to come down with steroids, but doesn't tend to give long-term damage. But unfortunately, some patients do have significant toxicities that never seem to go back to normal, but generally they will improve with steroids. I hope that answers the question.
We've got a question saying, cases you have presented here sound like they have experienced the cases you presented, the patients sound like they have experienced serious side effects. Is it like this for the majority of our patients?
So the answer is no. So I presented these patients to show kind of the sorts of things that we have to think about, and some of the more complex patients that we see. But it's not like this for all the patients. Like particularly the last patient that I presented, I think she's been very, very unlucky. But it is just examples of some of the damage that some of these drugs can cause.
We've got a question asking, how is immunotherapy effective when the first and second line chemotherapy failed on palliative patients?
So basically, in a lot of the cancers where we use immunotherapy, we might now use them first line. So, I mean, I don't treat every single cancer, but certainly in melanoma, we don't tend to use chemotherapy anymore because chemotherapy doesn't work. So actually first line treatment for melanoma is immunotherapy. Generally the cancers that we use them on, we will have a high neoantigen burden, so it's to do with the tumor microenvironment, and they tend to work with cancers with a high neoantigen burden. In lung cancer, I know that they do check their PD-L1 status, so they look under the microscope, and patients with a higher PD-L1 expression will respond to treatment. Will respond to treatment better than those that don't have a PD-L1 expression, but they work differently and as time goes on, as we do more trials where immunotherapy falls in the timeline of when we give it will differ with different cancers. So, and because they work differently, and even you can give first, second, third line chemotherapy. So initially, you give first line treatment and a patient will have response for a while, and then they'll relapse, and you'll give them different chemotherapy and they'll still respond because the mechanism of action of every single drug is a little bit different. I hope that answers the question.
There's one final question. Do we have time for that one?
Yeah, I'm happy to answer it.
Yeah, I'll just ask the EG bit. So does the risk of toxicity with immunotherapy accumulate with further time or therapy, or is it more a case that certain patients are just more likely to tolerate it and others more sensitive?
So the answer is the time on it doesn't make a difference. So you might see toxicity very early on, and actually with patients on immunotherapy, even after they've stopped treatment, they always have to remember that there is a risk of an immune-mediated toxicity even after cessation of treatment. So for example, in melanoma, when we give immunotherapy in the adjuvant setting, we give 12 months of treatment and then they stop, but we'll still check their thyroid function every 6 months. And if they come in unwell, you just have to have at the back of the mind that they have had immunotherapy in the past. So for example, they come in unwell, then you want to check their cortisol to make sure that their adrenals are functioning normally. So it's not necessarily related to the time that you've been exposed to treatment.
I think that's all the questions. So thank you so much. I'm sure you'll all agree that's been a fantastic talk, really, really interesting and helpful. Make sure you all fill out the feedback form. All of us, because they're doing this voluntarily in their evenings after their full-time jobs. So it's really useful for us to get the feedback. Make sure you register for our next talk on the 9th, and have a good evening, everybody. Bye.
Thanks very much. Good night.
Thanks.